Good afternoon, everyone. My name is Dominic with Ghana Medical Health. This afternoon on our maternity service agenda, we are looking at antepartum hemorrhage. Previously, I think 2 weeks ago, we had a great teaching on postpartum hemorrhage. It's only complimentary to have to know about antepartum hemorrhage as well, taking one of them specifically placenta previa. I'm sure this will refresh our knowledge and any updates that we may get as a result of this. Some few issues for us to take note of. I would mute you so that you'll be unable to unmute yourself so that the presentation can go on without any interruptions once she starts. However, the chat box is available so that if you have any question, any comment that you may forget at the end of the presentation, you can easily put it in the chat box whilst the presentation is ongoing. And then at the end of it, we can have a discussion around it. We are hoping to do the presentation in 30 minutes, then to allow for us to have a discussion after then. Thank you so much for joining us for today. I'm excited to listen to Dr. Velda and Dr. Howard. I'm sure most of us too would be. Kindly keep your microphones muted, and at the end of it, we have question time and discussion. Thank you so much. So join me in welcoming Dr. Velda, who would be leading us with this presentation. Dr. Velda, over to you.
Okay. Thank you very much, Dr. Dominic, and sorry everyone for
Dr. Velda, sorry if you could kindly speak a little louder. The voice is faint.
Okay. I'm Dr. Velda, a resident in obstetrics and gynecology at the Family Teaching Hospital, under the head of Dr. Atowomalie Agriwie, who is one of our panelists today. So we'll be talking about antepartum hemorrhage. Dr. Dominic, is my voice clearer now?
Yeah, but if you could increase it, it will be good. I actually strained to hear you. I don't know if it's from my end. Kelly, can you confirm?
No, very quiet voice. Yeah, hard to do.
Yeah, so
Can't hear
a
what's
couple of
being
people
said.
are sending messages that the volume is low. So if you could kindly speak up or get closer to the microphone of the computer or the phone. Thank you.
Okay. So as I said, we'll be talking about antepartum hemorrhage, specifically placenta previa. The scope of antepartum hemorrhage is very wide, so we are sticking to placenta previa for this afternoon.
Sorry. It's unchanged. We can't hear you. Somehow the speaker is too far away to hear what you're saying.
Okay. Is it better now?
No.
I think if you are using the fantastic, if you are using the earphone, just go off it. Yeah, it's great now. It's fantastic.
Okay. So we'll be looking at a few definitions before we delve into the topic. Antepartum hemorrhage is bleeding from or into the genital tract after the gestational age of viability, but before fetal expulsion. And placenta previa describes a placenta implanted in the lower uterine segment, sometimes completely covering the cervix. So here's a picture of what placenta previa basically looks like in the uterus. So you have the gravid uterus with the fetus, and the placenta is leading the baby. So at the cervical os, you can see that the placenta is covering, then the baby follows, which shouldn't be the case. Normally, you have the baby presenting first at the cervix, and then the placenta is high up in the uterine cavity. So in placenta previa, it's the other way around as depicted in the picture projected. So the abnormal location of the placenta can result in severe antepartum or intrapartum or even postpartum uterine bleeding. And it's one of the major complications of obstetrics of the gravid patients that we see commonly in our practice. It sequelae include the need for preterm delivery of the fetus, which comes with complications to the baby, cesarean delivery, hysterectomy, peripartum, maternal hemorrhage, and its complications. Mortality of fetus and mother are usually the most feared complications that we notice. So placenta previa typically occurs in 1 in 200 pregnancies, and the incidence is much higher in the mid-trimester, but usually 90% of them would resolve by the 3rd trimester, according to the American College of Obstetricians and Gynecologists in a study done in 2003. Another study has been done in Nigeria. It was a 5-year study by L.O. Omokanye et al., and it showed that the incidence in their Nigerian population that was studied was 164 cases in 10,250 deliveries, giving you a percentage of about 1.6%. Of this number, 67% were over 30 years, and 51.2% were grand multiparous women. In the United States, a large population study base was done for placenta previa, and the incidence was around 2.8 in 1,000 live births. The rate of placenta previa increases with increasing number of cesarean deliveries as well, with a rate of 1% after the first delivery by CS, 2.8% after 3 cesarean deliveries, and as high as 3.7% after 5 cesarean deliveries. So usually we classify placenta previa into 2 categories. We have the low-lying placenta, which is located in the lower uterine segment with an edge of the placenta within a distance of 2 centimeters or less from the cervical os, and then a second classification called placenta previa, which is when the lower uterine segment is where the placenta is located, and this placenta covers the internal os of the cervix. So basically, you have 2 types. One is covering the internal os. The other is encroaching so close to the cervical os, but it's within 2 centimeters from the os. Historically, we had other classifications. We had the marginal, the partial, or the complete previa. And these were classified into 4 other classifications, type 1, 2, 3, and 4. And with type 2, you had the classification of A and B, depending on whether it was anterior. So anterior was A, and posterior was B. So with that, type 2B, type 3, type 4 were all major placenta previas. And then type 1 and type 2A were minor placenta previas. So who is at risk of having a placenta previa? You have a mother of advanced age, that's greater than 35 years, a patient who has had infertility treatment or assisted reproductive technologies done on her, a multiparous patient, multiple gestation, a woman with short interpregnancy interval, previous uterine surgery, insult or injury, previous cesarean delivery, including first subsequent pregnancy following a cesarean delivery, previous or recurrent abortions, especially where you had dilatation and curettage done, previous placenta previa, non-white ethnicity, low socioeconomic status, smoking, cocaine use, endometriosis. So how does placenta previa come about? Usually, the placenta implants in the upper uterine segment. But in the case of placenta previa, you have the embryo adhering to the lower part of the uterus. For normal placentation to occur, that's in the upper uterine segment, you need the endometrial tissue environment to be good with a high blood flow. And also the endometrium should not have enhanced uterine contractility. I'll be explaining why you need all this. The uterus should be without a scar, an insult, or an injury. and the placenta should not be hypertrophic. Adhesion of the blastocyst should occur in the upper uterine segment, facilitated by certain mediators of implantation. However, with placental attachment and growth, the developing placenta begins to cover the cervical os in the case of placenta previa. And it is thought that a defective decidual vascularization occurs over the cervix, and this is possibly secondary to inflammatory or atrophic changes. And when this happens, you have the placenta tissue dying off, leaving bare vessels, which could persist as a vasa previa. And bleeding is thought to occur in association with the development of the lower uterine segment in the third trimester. So you have a sharing movement, which leads to separation of the placental bed from the uterus. And then the area left begins to bleed because of the vessels that have been exposed. So placental attachment is disrupted at this area gradually as the lower uterine segment thins out in preparation for the onset of labor. The lower uterine segment, like we know, has less myometrium compared to the upper uterine segment. So it's unable to contract adequately to stop blood flow from the open vessels once the placenta separates from it. The leaving ligature is not there as compared to the upper uterine segment. In the body's attempt to control bleeding, you have thrombin being released. However, this thrombin from the bleeding site promotes uterine contractions. And then you now have a vicious cycle of bleeding, more contractions, more placental separation, and more bleeding taking place. In the development of the placenta, we have a phenomenon called placental trophotropism. And this is the process by which you have atrophy of the margins due to poor vascular supply. As I said earlier, because of the thick myometrium and more vascular supply in the upper segment, the placenta would usually tend to migrate towards the upper segment in the third trimester, as the lower segment thins out and has less oxygen and blood supply to the placenta. So this also explains why placentas migrate more often when they are anterior than when they are posterior. Trophoblasts usually anchor the growing fetus to the placenta. And when this happens in a scarred tissue, as we would have in the case of uterine scars from cesarean sections or other uterine procedures, because of the avascular nature of the scar, low oxygen tension, and then a lack of decidual cells overlying the scar tissue area, you have prolonged maintenance of the invasive trophoblastic phenotype. And in these scenarios, the placenta tissue begins to invade more into the deeper structures of the uterus. And once they are anchored firmly to the deeper structures, placental migration would usually not occur. And you have the spectrum of morbid adherence, that is accreta, increta, pecreta, now taking place. Also in the pathophysiology of placenta previa, we have the theory of the placental hypertrophy. And this can be caused by carbon monoxide-induced hypoxia from maternal cigarette smoking, from multiple pregnancies, and from multiparous or older women. The placenta is a fastidious organ and would always look for a new place to attach. So if a woman has had many babies, you have the placenta getting more hypertrophied and moving into other areas of the uterus. In the situation of enhanced uterine contractions during implantation, you have abnormal uterine peristalsis causing implantation in the lower uterine segments. There are some associations of placenta previa. It's commonly associated with the placenta accreta spectrum, vasa previa, and placenta abruption. So for a woman with morbid adherent uterus, if she has had a first cesarean section, the risk of placenta previa is 3.3%, with the second 11, third 40. So this chart simply tells you that the more you have cesarean sections, the more your chances of getting placenta previa with subsequent pregnancies. And with that, you can have the invasion of the deeper tissues from myometrium, serosa, and even onto other pelvic structures or bowel. The other risk factors for morbid adherence are also displayed here, quite similar to the risk factors for placenta previa. Another association is vasa previa. So here you have two types, the filamentous insertion of the cord. So the placenta atrophies, leaving bare vessels, and this could either make it form a bilobed placenta or the filamentous insertion type of vasa previa. To diagnose placenta previa, it's usually done by ultrasound scan. So during the fetal anomaly scan, which is done at 18 to 20 weeks of gestation, you would pick up a low-lying placenta, but the scan will be repeated at 32 weeks. And then the final ultrasound scan done at 36 weeks. Transvaginal ultrasound scan is the best tool to use when you are doing ultrasounds for patients with low-lying placenta. We routinely do transabdominal, but the transvaginal is the preferred one. So usually the symptom is a painless, bright red vaginal bleeding. And this can happen on one occasion or several occasions. The first bleeding is usually called the herald bleeding. So it's usually a warning bleed, and the next will be more torrential. But you could have patients who do not have this. They could also have malpresentation of the fetus and signs of hemodynamic instability. But the painless bright red vaginal bleeding after the gestational age of viability is a sign you should always look out for. The differentials could be a bleeding vasa previa, cervical or vaginal laceration, vaginal sidewall laceration, a miscarriage. That's for when it comes before our gestational age of viability, but we must know that in other countries, they have an earlier gestational age of viability. Infections, lower genital tract lesions, bloody show, and placenta abruption. So usually the management of a patient with placenta previa depends on whether the patient is asymptomatic, is stable after one or more episodes of bleeding, has active antepartum bleeding, or whether she is a refractory patient. So for a patient who has active antepartum bleeding, you would usually resuscitate to achieve and maintain hemodynamic stability. To do this, we secure IV access with large bore cannulas. We take samples for full blood counts, grouping, and cross-matching, coagulation studies. You can do other tests like a renal function, liver function, or depending on the patient's specific situation, you would want to do other tests. I usually start resuscitation with your crystalloids, normal saline or Ringer's lactate. You secure between 3 to 4 units of blood for transfusion. Pass a urethral catheter to assess your tissue perfusion by the urine output. And then immediate delivery is done via cesarean section. Mostly during a cesarean section, the problems you encounter are postpartum hemorrhage, difficulty in controlling the bleeding especially from the placental bed. So to reduce this at cesarean section, we administer uterotonics once the fetus is born, and then we give tranexamic acid once the fetus is born, but you never give it before delivery of the fetus. And then temporizing maneuvers like bimanual compression, aortic compression. This is usually done when you don't have the skill to continue to do the other more definitive ways of managing postpartum hemorrhage. So whilst they are waiting for a senior colleague to come, you can do this, but they are not treatment modalities. Then you treat focal bleeding points with hemostatic square sutures, placental site injection of vasopressin, uterine compression sutures, intrauterine balloon tamponade, ligation of uterine and utero-ovarian arteries, like the O'Leary stitch. For refractory patients, we do arterial embolization and hysterectomy. Now, if you have a patient who comes and she's stable after a heral bleed, usually, sorry, after CS is not supposed to be here, but usually after a heral bleed, that may be the first sign that she has a previa. You admit her to the ward, you assess mother and fetus, you do your baseline laboratory test, and you notify your blood bank for blood. Autologous blood donation can be done. You stabilize the patient, gain intravenous access and administer crystalloids. You give rescue corticosteroids and max sulfate to protect the preterm fetus. Because the risk of delivering that fetus prematurely is high. You correct anemia, and then you give anti-D immune globulin for patients that qualify for it. And you manage concomitant premature or pre-labor rupture of membranes. So all this has to be done as an inpatient management. For an asymptomatic patient picked up before 37 weeks, you apply the McAfee and Johnson's protocol. This can also be done for a patient who has had a heral bleed, but it's not severe enough to deliver the fetus yet. So you admit her to the ward, ensure her HB is greater than 10 grams per deciliter. You encourage bed rest, daily inspection of the vulvar pad, encourage patients to report to you promptly if she's bleeding. You avoid inserting fingers into the vagina, and she should not have sexual intercourse till delivery. She's supposed to inform medical staff if she's using the lavatory. Sometimes they collapse from bleeding heavily in there, so they have to alert you. And then they do a 2-weekly HB check to make sure that HB is always above 10 grams per deciliter. You secure blood for emergency bleeding situations. Then you also do a fetal well-being monitoring. So fetal cake counts daily, 2-weekly biophysical profile, Doppler velocimetry. It's usually associated with intrauterine growth restriction as well. Twice daily auscultation of the fetal heart rate. You repeat the ultrasound at 36 weeks for the type and the degree of previa. So once you catch a patient with placenta previa prematurely, you keep on your ward till delivery. Whilst on the ward, you have to plan your delivery. So usually the mode of delivery is via elective CS for major previas, and delivery is done by 37 completed weeks. It can also be done based on other obstetric indications. And then vaginal delivery usually can be allowed for type 1 and type 2A placenta previas. If you have to deliver the preterm fetus, it would be because of recurrence of hemorrhage, intrauterine fetal demise, or congenital malformations. So 2 units of blood have to be secured for immediate transfusion, and you always keep the patient on supplementary hematinics. Maternal complications include hemorrhage, anemia, shock, end organ damage, blood transfusion, and its accompanying problems, placental abruption, preterm delivery, cesarean hysterectomy, an increased incidence of postpartum endometritis because of how close the placental bed is to the cervical and to the vagina, which is not sterile, and eventually mortality. Fetal or neonatal complications include congenital malformation, intrauterine growth restriction, fetal anemia, and rhesus isoimmunization, abnormal fetal presentation, low birth weight, neonatal respiratory distress syndrome, jaundice, admission at NICU, long hospital stay, increased risk of neurodevelopmental delays, and sudden infant death syndrome. Neonatal mortality rate is as high as 1.2% in the United States. So thank you very much. These are my references. Thank you for listening.
Great, excellent. Thank you so much, Dr. Velda, for an excellent presentation. I've learned a lot. I'm sure a lot of our people have on the participant list have learned a thing or two as well. And it was concise, straight to the point within the 30 minutes. So we have good time for people who may have any questions, any comments, any suggestions. Like we always say, this is a learning platform. So if you have anything to add on to what the presentation is, please don't feel shy. You can unmute yourself and then you do that. There isn't a wrong or right answer. It's all about learning. So don't feel shy. Hit the unmute button and then either make your contribution, ask your questions, or make any suggestion that you would have. It's designed by us for ourselves. So it's all good. So we have a good time now. If anyone has any question, I've unchecked the box so you can unmute yourself and then go ahead. If you have any question, please go ahead. Just unmute yourself and then you ask, or if you have a contribution, please do so. The floor is open, please.
Boss, good afternoon.
Good afternoon. Yes.
Yeah, this was a great presentation. Thank you so much, Dr. Velda. I don't know, at the portion of risk factors, I heard the presenter indicate that non-white descent is a risk factor. But I think in the slides, appears the epidemiology was saying otherwise, because it looked more common in the United States as compared to the research that was conducted in Nigeria. I don't know whether maybe I didn't get that clearly.
Okay. Yeah, so Dr. Velda, he wants clarification on that.
Okay, so it's actually common with us. However, the United States seem to appear more frequently because of data. Okay, we presented some data from Nigeria, but apparently when you go to the references, mostly it's the data from the United States that's published. That is common in Asians and in the Black race and non-Hispanic whites. So we are at more risk compared to the white race. Yeah.
Great, thank you. Dr. Betty, I see you've unmuted yourself. Please go ahead with your question. Okay, so she's muted. Anyone with any other question? Please just unmute. Yeah, Rukaya, please go ahead.
Yes, please. It's kind of a clarification on the treatment. She mentioned that we cannot give tranexamic acid to the client if the fetus is still in utero. So I want to find out, is it only in the placenta previa or in all pregnant women you can't give tranexamic?
Great, Dr. Velda.
So we don't give tranexamic acid to all pregnant women. It crosses the placenta and gets to the fetus. So we don't give it in pregnant women at all until the fetus has been delivered. We use it for the management of PPH, postpartum hemorrhage in obstetrics, not antepartum hemorrhage.
Great, thank you. So obviously, not before delivery. The baby should be out before. Techno Spark Go, please go ahead with your question. I don't know who your name is because you haven't named your. Good afternoon.
Hello, good afternoon.
Yes, please go ahead.
You talked about you talked about warning bleeding, like for the placenta previa. I want you to elaborate on that one for me.
Okay, great. So she wants
Okay.
an elaboration. Yeah, please go ahead.
So as we described in the pathophysiology, as the lower uterine segment is forming, you begin to have the sharing movements, which would cause the bleeding. So usually the first time the patient bleeds is just a warning, because that movement is going to continue up until the time the lower uterine segment forms. So by the time she'll be having the next bleeding, it's likely to be torrential.
Great.
Because
PA.
the movement is more.
All right. PA Abdullah Mohammed, please go ahead. Unmute yourself and go ahead.
All right. Thank you very much, Dr. Dominic. I must say I'm very happy for this topic. Was one of our obstetric emergencies that do come to us. But there's something small I want to know. With the APH, let's take abruption, for instance. So if a woman comes with abruption, then all indications show that's abruption. And the bleeding perhaps is minimal. Let's assume like conceal. Can you go ahead to induce such a client to deliver SVD, or it must be a CS kit? Thank you.
Dr.
Okay,
Velda.
thank you for your question. Yes, so if a woman comes in and your diagnosis is abruptio placenta, you have to empty the uterus. Now, the mode by which you empty the uterus will come from the assessment you have done. So abruptio, for the rest of us who are listening, this presentation, we're talking about placenta previa, which is one of the 2 common causes of antepartum hemorrhage. The second common is the abruptio that he's asked the question on. And for that one, it is premature separation of the placenta before delivery of the baby. The placenta should separate when the baby has been delivered, but here the baby is still inside and then the placenta too has separated. If you make that diagnosis, you assess both the mother and then also the baby and the cervix. If your assessment shows that this bleeding is minimal, the woman is stable, I have blood and blood products available, I have done a vaginal examination, the baby is coming with the head, the cervix is favorable, she's probably 4 centimeters dilated. I have done a scan and I am very certain that this is not placenta previa, it is placenta abruptio. Then you can make that choice of having her deliver vaginally. But if you do your assessment and the baby is alive, remember the placenta has separated, the baby is alive. If you are going to wait and let this woman deliver vaginally, you may end up losing the baby alongside. So once the baby is alive, your quest is to do the most fastest delivery possible. If she's close to about pushing the baby out, 8 cm, 9 cm, fully dilated, then you can expedite vaginal delivery with a vacuum. But if she is still 4 cm, baby is alive and it's an abruptio, you better go and do cesarean section. If not, you will lose the baby alongside. But if the baby has already died inside and the mother is stable, you have blood products, your theater is available in case you have to rush into theater, then you can make that choice that you would want her to expel vaginally. And truly, they expel very fast. Once you set up oxytocin and rupture the membranes, you set up blood on one hand, the other hand, she has the oxytocin running, and within a very short time, they progress, and then you can have a safe vaginal delivery. But you should always watch out for PPH. Every APH ends up probably in another PPH. Thank you.
Thank you very much, Dr. Great. Any other question, comment, suggestion? Please unmute and go. Deborah, please go ahead.
Okay, please, in the management, I think I saw magnesium sulfate administration. And I just want to ask, this one, what are we using it for? Is it as an anticonvulsant or as a uterotonic? So I just want the doctor to clarify the magnesium sulfate that was part of the management.
Okay.
Okay. If I heard you right, you're asking about magnesium sulfate.
Yes, please.
Okay. So it has benefits to the fetus, the preterm fetus. It's given for neuroprotection in the baby. As we said, mostly they will bleed when they are preterm, and you have to deliver the mother. So it's to give neuroprotection to the baby, because the head might pass through the birth canal, or as you are delivering, you may injure the brain. Okay, it eventually prevents cerebral palsy. So we give it for the fetus. Its benefit is not to the mother. So it's actually indicated in in preterm delivery, where you know that you deliver a preterm fetus.
Great. Any other questions? Deborah, were you going to come back? I saw that you unmuted yourself.
No, please.
All right. Thank you. Any other question? Yes, Esther, kindly unmute yourself and go ahead. Esther.
Thank you very much. Please, I would like to know how many grams of the mass of to give in this instance if you are very sure that the labor is preterm. Thank you.
Great, thank you.
Okay, so for the giving max sulfate for neuroprotection, like Dr. Velda said, once the baby is less than 32 weeks, we believe that once you give some max sulfate, it helps with protection of the baby's brain when the baby is born preterm. The amount of max sulfate that is given for this purpose is similar to what we give to the mothers for eclampsia, when they get eclampsia, except that we don't give the IM dose. So like in eclampsia, you would have given 14 grams loading dose, and then you give 5 grams every 4 hours. But in this one, we will give the IV portion of that 14 grams, which is the 4 grams IV, and then you should continue with 1 gram every hour if you have an infusion system. But if you don't have an infusion system, then you can go on with the 5 grams that we give every 4 hours like we do. So you just omit the 10 grams for the loading dose. So the loading dose would now be 4 grams, and then you continue 5 grams every 4 hours. Or if you have a way of giving, if you have dorsiflow, for instance, then you can put the 5 grams in 500 mils saline and give her 100 mils per hour as an infusion. Thank you. And it's for 24 hours. For 24 hours. You do that for 24 hours. So we do that when we are giving the DEXA, knowing that maybe this bleeding may become worse and we may have to deliver. So you are giving the neuroprotection, then you also give the DEXA to mature the fetal lungs. And then if things don't go the way you want and you are not continuing with the conservative management, then you go ahead and do a delivery. And the baby's outcome is much better.
Great. Thank you, Dr. Awa. Bashira too, please unmute and go ahead.
Hello, good evening.
Good evening.
Thank you so much for presentation. Please, my question is about the magnesium sulfate. We know that it has a tendency of, how do we call it, relaxing the muscles to prevent contraction. So as we are managing this labor and then we want to hasten delivering, if we give the max cells, won't it interfere with our delivering process? Thank you. And also the tranexamic acid, most of threatened abortion, can we give it in a threatened abortion? Thank you.
Thank you. All right.
Okay, so please let's remember that when we spoke about the labor issue, we were answering a specific question on abruption. When it comes to placenta previa, the nature of the problem is that the placenta is covering where the baby is supposed to come through. So rarely will you have a successful vaginal delivery when there is a placenta previa that is bleeding. So labor and delivery does not come in here quite often. You would only have that happen when you were monitoring this woman who had a low-lying placenta, and then subsequently, as you were doing the repeated ultrasound, like Dr. Velda said, 32 weeks, you now realize that, oh, the placenta has gone a little further away than the 2 centimeters we mentioned. Then in that case, when such a woman goes into spontaneous labor, she can have a vaginal delivery. Most often than not, in placenta previa, they end up with cesarean section, either immediately when they come in bleeding, or subsequently when you've monitored them and the baby is now mature, yet the placenta is still in the lower segment. The safest route of delivery is a cesarean section so that you can control the problem. We spoke about labor when we're answering the question on abruption. Now, even in that case, even when you have an eclamptic and you have to give magnesium sulfate to control the fits, and she's in labor, if you're worried about slowing down of your uterine contractions, what do you do as a midwife? You augment the labor with oxytocin. So if you think your contractions are not going fine because you've given some magnesium sulfate to your eclamptic and then the contractions have gone down, you do your contraction checks and you are not getting 3 in 10 lasting 40 to 60 seconds, then you set up oxytocin on the other side so that your patient will not fit, but then the contractions will go on, because it's very important that you prevent the fits.
Great, thanks for the insights. Any more? Anyone with any question? Yes, unmute yourself and go ahead.
Yes, please.
Okay, there was a second part of the question
please,
that was
my
about
question is,
tranexamic
you are
acid.
in a
Hello?
Hi, so Elizabeth, can you kindly hold on? Let
Yes,
Dr.
there was
Awa
a second part of the question that asked about what about tranexamic acid being given to for threatened abortion. So if you read the literature on tranexamic acid, they are quiet on what it does to the pregnant woman and the baby. We know for sure that it crosses the placenta. There is not enough data when it comes to these kind of drugs. Nobody does any trials on pregnant women. So until we start having records to say that this is what happens, then it is not something we can stick our necks out. But when you read the literature, it tells you clearly that the tranexamic acid crosses the placenta and fetal levels are as high as maternal levels. So it is just not okay to use them. I know that people throw it in here and there when they see any form of bleeding, but let's be careful whilst we do these things, because we have no concrete data to tell what happens to those babies that are exposed to tranexamic acid, be it first trimester or later on in pregnancy.
Thank you. Elizabeth, please go ahead.
Please, my question is, assuming you are in a health center or CHIPS compound whereby a client comes to you in labor, after assessment, she hasn't done any late scan to either rule out previa or those abortion. When you assess her, she was already in second stage, let's say 9 cm or 10 cm fully dilated. Should you go ahead and deliver the client, or you should?
Okay, so for this one, this scenario is not likely to be a previa, because before she would get there, she would have bled out, or the placenta, you see it hanging at the vagina or at the cervical os. But let's say it's a previa, then your best bet is to get the baby out as quickly as possible. So you help her to deliver as quickly as possible and then prepare for the postpartum hemorrhage. So you do your active management, your uterotonics, what you have to do at the health center, and quickly move for the PPH to be managed. but it won't be wise to leave the baby there and now be struggling to move both mother and baby to the hospital. That is what I would advise you to do.
Okay,
Great.
thank you very. But in this instance, assuming it's the placenta that is covering the whole of the cervix, is that you are delivering the placenta first, or is the baby when it's fully dilated?
So I really pray that you don't get yourself into this kind of situation, because that is being torn between the devil and the deep blue sea. If you put
Yes.
your hand there and you feel that spongy tissue, that it is
Yes.
placenta, sometimes you can't even get your hand out and the bleeding is coming. You just know that you are in bad business once you poke the placenta that way, because it's the raw end of the placenta that's going to be showing at you, not the part that is with the covering of the amnion and chorion. So it is very, very difficult, a very difficult situation. If you put your hand and you feel that spongy tissue, please get your hands out and get the patient to the nearest hospital as quickly as possible. Because if the head has not passed that placenta and you are going to try and do any maneuvers to deliver the baby while the placenta is covering that place, you are going to be in trouble, especially in a small center like a health center. It's, if you have any doubt when you do VE, you put your hand there, I'm not feeling what I'm feeling. It's not fetal part, it's not buttocks, it's not head, it's some soft tissue. It could even be cord mixed with something. Please don't force and do the delivery. Refer as quickly as you can. This is the one that your hand is inside the pelvis and you are sitting in the ambulance. I don't want to imagine that.
Great. I'm sure, Elizabeth, you're good now. Esther, please go ahead. I see your hand.
Okay, boss, please, I'm just wondering if, based on past experiences and what we've learned, that is, it seems better to avoid digital vaginal examination, just like doctor is putting it now. So maybe since this is a big platform, could we unanimously agree that maybe perhaps if the ultrasound has confirmed that it's previa and the client comes in bleeding, maybe perhaps you could do some speculum examination to see, maybe just to observe how far cervix has dilated or something, and avoid the hand. Maybe we may peel the placenta off and cause some kind of abruption or something. Because the way she's describing it, I'm scared listening to it. Before we may be attempting to see how far it has dilated and see whether we could augment or should we refer or something. We should avoid rather putting our hand there if only bleeding has already started. Thank you.
Okay.
Great.
So to answer this, it's the dictum. Once you diagnose placenta previa, no V, no speculum to see what is happening there, nothing. Just refer. The standard is to do an ultrasound scan. So if you do it at 18 to 20 weeks, it's a previa, please refer to the next higher facility for her to continue her antenatal and everything. Remember, in the management, she's even supposed to be on admission till she delivers. No baby, no home. So you have no business keeping her with you. Once the scan diagnoses a placenta previa, let her go. If with subsequent scans, the placenta has migrated, fine. It will be handled from that level. So that brings me to something they used to do in the past to make it more scary, so that you never put your hand there. They used to do the double setup, where before you put your hand, you are in theater. So the examining midwife or doctor at the vagina, anesthetist at the head, ready for anesthesia to be given. And you too, you have scrapped, ready that the moment you put your hand and she's bleeding, the next thing is CS. She's positioned, ready for CS. Everything is prepared. Instruments are set up, scrap nurse is standing. That is the only situation that you can put something in the vagina to examine. So I pray you don't have such a situation as my boss has explained, because you can't get out of it. But the only time something can be put in the vagina is a transvaginal ultrasound probe to assess and see whether it is truly a placenta previa. But no digital examination, no speculum examination. Previously, we used to say speculum. If you don't have a scan, refer to where they have a scan. It's a scan first. Rule out a previa first before you do a vaginal examination.
Excellent. Thank you so much, Dr. Velda and Dr. Howard. We've done about 30 minutes of questions and discussions. I'm sure a lot of our issues have been clarified. In keeping with the timing, we will not want to go beyond the 4 o'clock. And so we want to bring the curtains down at this point. However, I just want to pass in some few comments. Number one, a couple of people put in messages in the chat box asking for slides. So if you look in the chat box, like I indicated previously, and now just putting up again, you realize that I've numbered Sorry, my network went off. Dr. Howard, can you hear me?
Yes, we can hear you.
Dr. Velda, can you hear me?
Yes, please.
Hello?
We can hear you.
Hello?
Hello.
We can hear you.
Can anyone hear me?
Yes, we can hear you. We can hear you loud and clear. Dominic,
Can
we
anyone
can hear
hear
you. Oh.
Can you hear me now?
Yes, we can hear you.
Oh, great. Yeah, so sorry, I think my network went off. I was just mentioning that a couple of people put in the chat box about how to get the slides and how to get alerts for these meetings. So I just wanted to alert you that number one, for the slides, like I've put in the chat box and putting it in again now, for getting the slides, just like our YouTube page, once that's number 2, like you see in what I've put in the chat box, you click on that and then you can like the YouTube page. Now, when you go there, both the video recording of this meeting will be put up so that then you can watch it if you want to watch. You can download it and keep it if you want to. Also, when you click on the comment section of that, the presentation in the YouTube, you'll find that the slides will be there as well for you to be able to read if you want to. Now, others also asked about the alerts on the presentation. So, like I always mention, if you just remember that on a Friday like this for 1 hour between 3 and 4 o'clock, there's a presentation. You can use the same link that you used to join the meeting today. It's the same link as always. However, if you want to know what the topic is, click on in the chat box I've just put in our Facebook page. So you click on that, you like the page. Usually before about 72 hours to the presentation, we usually put up the topic up so that then you get to know what topic it is. However, if you are not even able to look at that, but you just remember that on a Friday you want to join a talk on maternity, then you can just use the same link, the same one you used to join this meeting today. And then a couple of people also joined and asked that they could not hear. I think a lot of us could hear. What I noticed was that those who put up that did not connect with their microphones. So usually when you join the Zoom meeting, it will be, there are 3 options that come up. Please select the that you join with the microphone, either by Wi-Fi or any of that. When you do that, then you'll be able to hear us. These are the three that I just wanted to alert us to, and to thank you so much for joining us for this presentation. Hopefully next week we'll come your way with another presentation on maternity service agenda. Also on Thursdays, usually we have other multidisciplinary management other than obstetric. So Friday is dedicated to obstetrics, Thursday is dedicated to every other aspect of medicine. So you want to learn about medicine, about pediatrics, about surgery, about medicine and the law, about physiotherapy, dietitian. We've assembled a big panel usually on Thursdays to take each topic to look at. Last week, we did medicine and the law, medical legal practices. A lawyer and a doctor led us with that. So same way, if you remember on a Thursday that you want for an hour to learn something about medicine other than obstetrics, either medicine, pediatrics, surgery, pathology, any of the other disciplines of medicine. You remember 3 to 4 p.m. on Thursday, you use the same link you used to join this meeting. You'll be at the right place as well. So these are the comments for you to remember. Thursday is 3 to 4 p.m. Stevenson, like you're asking. So same time Thursday, same time Friday. I just want to, on behalf of all of us, thank Dr. Howard and Dr. Velda for an excellent job done. We've learned a lot. We are grateful to you for making time to take us on this presentation. We are grateful. I'm sure it will go a long way to improve the service delivery for most of us, especially in rural practice in Northern Ghana. Thank you for joining us. Also, a quick one, if you do have any presentation that you want to make, don't hesitate to reach out to us via either the same platform that you got this, or through Facebook, or through the LinkedIn account, and we'll be able to schedule you to make your presentation. We know we cannot pay you, but usually we are able to give you some stipend for airtime credit. So for 30 minutes of your presentation, we usually send 500 CD airtime credit, money for you to use for airtime credit for the time that you've dedicated to this. We know it's in no way payment to you, but it's a way at least to be able to cover your airtime. So don't hesitate. If you have something that you want to share with the rest of the world, with the rest of us in Northern Ghana, in rural practice, they say knowledge is power. Don't keep it to yourself. Today you are the doctor, you are the nurse, you are the midwife. Tomorrow you may be that patient who needs help in that village where there's only one man. If you don't, then it becomes an issue. But if we keep educating ourselves, I'm sure we'll all develop. So it's open to all of us. Reach out to us via Facebook, Ghana Medical Help. Reach out to us via the LinkedIn account, Ghana Medical Help, and we'll respond appropriately. Thank you so much. Yeah, I see someone hands up. I don't know if you want to pass the comment and then we go off. TCL, who is this, please? You can go ahead. Okay, I'm sure you probably inadvertently put up his hand. So thank you so much for joining us for today. We are grateful. See you next week and take good care of yourselves. A big thank you, Dr. Howard. Big thank you, Dr. Velda. God bless you all. Bye-bye.